It is now my pleasure to introduce our next speaker, Katie Orem. Katie is the Geriatrics and Palliative Care Program Manager, as well as the MOLST Administrator for New York State at Excellis Blue Cross Blue Shield. As a reminder, this session will be recorded for educational use at a later time. Katie?
Hi, so I'm Katie Orem, and I'm gonna share my screen directly here so that you guys can see. And I wanted to encourage everybody to ask questions live during my session. I think that I'm gonna be explaining some complex differences, and some of what I'm explaining today, it applies to everybody 18 and older, not just people who have intellectual or developmental disabilities. So I really want you to be able to engage with the material and have your questions answered as we go. And so please feel free to interrupt me, so to speak, with questions live in the Q&A. And I'll do my best to answer them as we work together. So I'm going to talk about two different advanced care planning programs and explain the differences between traditional advanced directives like a healthcare proxy and living will versus MOLST, which is a medical order like a prescription. We're going to talk about initiating advanced care planning for everybody 18 and older, including people with developmental disabilities or intellectual disabilities, and then talk about MOLST as the person-centered end-of-life care transition process and program for our most seriously ill people, including people with intellectual or developmental disabilities who are clinically appropriate. And then I'll show you MOLST briefly, which is really best practice in ensuring that these conversations remain patient-centered and that all of the ethical and legal protections that are built into our laws are always respected when completing these important medical orders for those very seriously ill people. And again, I really want to direct you to this awesome webpage that CCN set up for us today. All of my slides are going to be available there. There's some slides I'm not going to present, but they're more as like background or resources for you guys. This has been, I think, will be a great resource for you. So Dr. Dwanzik discussed palliative care as interdisciplinary, and I always say there are three key pillars: advanced care planning, pain and symptom management, and caregiver support. And we're gonna really focus on that advanced care planning component. And when is advanced care planning appropriate? It starts at age 18. People should be completing a healthcare proxy and living will. Literally starting at age 18, we encourage people to consider healthcare proxy completion, you know, when they're transitioning to an internal medicine or family medicine practice, perhaps away from a pediatrics practice, when they're applying for college if they're 18, or going to college if they're 18. For everybody else in the population, when they turn 18 is a great time. You know, it's a marker where, you know, you have a lot of more sort of legal accountability, including the ability to do a healthcare proxy for the vast majority of us. So I know that there are many folks on the line here today. Statistically, not all of you have healthcare proxies. So that's like sort of your #1 homework from my session is please go home and do a healthcare proxy for yourself. Have these conversations with your family. And so palliative care is integrated, can be integrated from the time of diagnosis. And there's great evidence actually that for very serious illnesses, integrating palliative care earlier may actually prolong people's lives, not hasten their deaths. And as patients' illnesses continue along a disease trajectory, the percentage of their treatment that is focused on palliation versus on curative treatment shifts. As maybe some treatment doors close to them, palliative doors open to them sometimes. And so you see this, you know, at the top of this graph, you know, you see this like long triangle section. On the left side, you know, almost all of treatment is that medical management for chronic disease from the time of diagnosis, and palliative is a little bit maybe. And it depends certainly where in a disease process a patient is diagnosed. And then as time goes on, right, the medical options for managing this person that are not palliative may get smaller and smaller. And the palliative portion gets bigger and bigger. In the last year of life, or potentially for some patients in the last 2 years of life, is when we recommend initiating those advanced care planning conversations for those most seriously ill patients that it wouldn't surprise us if they died in the next year. And then in the last 6 months of life is when we talk about, is it the right time to go on hospice? So advanced care planning is this process of planning for future medical care. And it happens through the life course. So when we're healthy and independent, we do our healthcare proxies. And if you guys have questions about living wills, please ask them. I'm happy to answer them. Healthcare proxies for everybody 18 and older. And it simply designates who's going to speak for you if you can't speak for yourself. And when I say you, I mean you. You guys who are listening today, in addition to the patient population that we're talking about, many of those folks can do healthcare proxies as well. Even with their intellectual and developmental disabilities, they have the capacity to say, I trust my mom to make my healthcare decisions, and my sister is the backup, or I trust my brother to do this for me, or this very close friend who's been involved in my life. And so we recommend that healthcare proxy completion start as early as possible at age 18, and then continue through the life course. This document should be revised, and those conversations should be repeated about what matters most, what's important to the person. On the right side of this rainbow, that's where MOLST becomes appropriate, typically in the purple and pink sections. There are occasionally some people who might actually be more like in the blue section, early diagnosis of a terminal illness, and they know what that disease looks like, and they may want to make some upstream decisions. Example would be dementia, sometimes patients with ALS. They know what that trajectory is going to look like. We had a great question from Brittany here. What if the person is not verbal or not able to self-advocate? And absolutely, the capacity to do any of the items that we're going to talk about today, whether it's complete an advanced directive or complete MOLST with a physician and the medical team, that capacity is task specific. So if the patient does not have capacity to understand what a healthcare proxy is, or to explain who they trust to make their medical decisions, then they can't complete a healthcare proxy. However, too often, patients with intellectual and developmental disabilities are presumed to lack this capacity without an evaluation to really determine, can they understand that kind of distinction? Because the ability to make complicated medical decisions, is up here. And the ability to choose a healthcare proxy and say, I trust my mom or trust my sister to make healthcare decisions is down here, right? They're not the same. And so this capacity is really task specific. And this is why healthcare proxy completion for the patients with intellectual and developmental disabilities has special protections built into it, because we certainly recognize, we don't want these patients to be manipulated into choosing certain specific people, but also they need to be protected during this process. And so one of the witnesses on their documents, and Laura Vivacqua can get into this more in her session, it has to be very specific in our state to ensure that the patient had capacity to understand what they were doing when they were doing it. And evaluating patients for the ability to complete a healthcare proxy as early as age 18 is absolutely appropriate, because that's a legal document that all of us should be having the opportunity to do as much as possible. Okay. Thank you for that question, Brittany. So there's some huge differences between those advanced directives like a healthcare proxy or a living will and medical orders like MOLST or non-hospital DNR, or you might have heard it called POLST if you've been to Pennsylvania. Different states have different names for those programs. So I'm going to talk about advanced directives first. Healthcare proxy and living will, again, for everybody age 18 and older. In New York, you may not realize this, living wills are not a legal document. They're recognized in our state by the courts as proof of clear and convincing evidence of a patient's preferences when they have both a terminal and an irreversible illness, right? And this is an important distinction because the living will is just as valid as conversations with your family. Repeated oral expression is also clear and convincing evidence recognized in our state. If I wrote my preferences in an email and emailed them to my family, that would be clear and convincing evidence of my preferences. All of those routes meet the criteria for clear and convincing evidence. But in New York, there are fewer and fewer routes where clear and convincing evidence is required for a surrogate decision-making. Specifically, it is no longer required in inpatient settings in our states, actually for the last decade. But in outpatient settings, there are some circumstances where those documents could become valuable. I will tell you on the whole, living wills are proven to not work very well. They're not very effective because they're completed ahead of time, far in advance of a disease process sometimes. They don't reflect the medical situation at hand. So you'll see, living wills written in 2005 that said, if I end up like Terry Schiavo, like that's this many people, that's not a common situation. And so family is left wondering like, well, that's not the situation at hand, grandma, like what are we supposed to do here? So it's absolutely not a replacement for the conversations with families about values, beliefs, goals, what matters most. It's definitely not a replacement for the healthcare proxy in our state, which is the only legal document to designate a medical decision maker that comes from the patient themselves. And no one can do a healthcare proxy for you. If you don't do a healthcare proxy for yourself, no one can step into your shoes and complete that for you. Only the patient can do a healthcare proxy for themselves. And so unfortunately, sometimes I encounter family members of patients who have severe developmental disabilities. They do not have the capacity to understand what a healthcare proxy is. I would use my cousin as an example. He has charge syndrome. He has probably the capacity of a 3 or 4-year-old child. He doesn't understand what a healthcare proxy is. And he would not be able to complete one. And I've had parents sometimes of these children, as they've aged, parents realize their child's going to outlive them. And they want to do a healthcare proxy for their child to designate a specific decision maker who's been involved in their child's life. That cannot be done. Similarly, if you do a power of attorney in New York, they have no authority when it comes to making healthcare decisions. Only you can designate somebody on a healthcare proxy form to indicate who should make those medical decisions when you can't. So it really is, there's a lot of protections in that respect already. And then for these intellectually and developmentally disabled people, there are additional protections written into how the witnessing on those documents occurs. So healthcare proxies and living wills are always completed ahead of time. They only apply when decision-making capacity for those medical choices is lost. So they don't apply today. I did my first healthcare proxy at age 19, and I have never had to use it. I've updated it probably like 3 times. First it was my dad and my mom, and then my mom was the alternate agent. And then my sister turned 18, and I made it my dad, my sister, and then my mom. My sister and I are like kindred spirits, like, we know each other so well, and we would be able to easily speak on behalf of the other one. And I know she'd be able to separate herself from, what she would want from me versus what I would want for myself. So that's really important criteria in choosing a healthcare agent. And, when I got married, I was 24, and I said my husband would do a really good job with this. And so I made it my husband, my dad, my sister, and my brother had turned 18 by that time, and my brother, and then my mom. So you can see, I keep pushing my mom down the list because I didn't believe that she could do that she could separate what she wanted from what I wanted, particularly if we were in a situation where all these other people weren't available. Something pretty bad would have had to happen. You know, because in New York, you work down the list in order of priority. You're not allowed to name co-agents. The way you can name a co-agent on a power of attorney document, you cannot do that on a New York healthcare proxy. And the medical folks on the line are like breathing a sigh of relief that you can't have like 8 co-agents who are forced to act together on this. No, they have to be listed sequentially. But you're welcome to go on and on in attaching documents to your healthcare proxy. In contrast with that healthcare proxy, which is completed ahead of time, only applies when you lose capacity, MOLST applies today. It's not conditional at all on losing capacity, but it's only offered when you're seriously ill and closer to the end of life. Remember the purple and pink sections from this slide. Multiple comorbidities, increasing frailty, wouldn't surprise us if they died in the next year. And if you have lost capacity, your healthcare agent or surrogate can complete the MOLST with your physician or your nurse practitioner or your PA. And for patients with intellectual or developmental disabilities who don't have a healthcare proxy and can't do one, like if my cousin were appropriate for MOLST, it would only be his attending physician who would be able to do that MOLST with his surrogate decision maker. We're going to talk more about that. So MOLST is a set of medical orders. It's not, you know, general preferences for care. It's very specific to the situation at hand, and it's only offered when the patient is clinically appropriate for that end-of-life discussion. It's not offered ahead of time. So this chart is nice for comparing MOLST versus advanced directives like the healthcare proxy and living will. And so there might be some folks in the audience who have called MOLST an advanced directive in the past. It is not. We have to correct our language because patients and families do hear us say that and they misunderstand what MOLST is. They think MOLST is like a living will on steroids. It is not. MOLST is only for patients who are seriously ill. It is only done based on current health status, current prognosis, current goals, and it is for current treatment preferences, meaning it's actionable as soon as the physician, NP or PA, signs those orders. And in the case, again, of those intellectually or developmentally disabled patients who don't have a healthcare proxy and can't do one, it would only be the physician signing those orders. NPs and PAs are not permitted to complete that pathway. And then the resulting forms are obviously very different, right? Only patients can do their healthcare proxy, and the end of the day, you get a healthcare proxy or a living will, and those are advanced directives versus a MOLST, or as it's called, POLST, in lots of other states. If you guys have family members in other states, you're curious, you know, maybe grandma lives in Florida, you can check POLST.org to see the programs available in other states. The healthcare agent or the surrogate can complete the MOLST when the patient is clinically appropriate but lacks capacity, but no one can do a healthcare proxy for you. Only you can do it for yourself. Providers and their team members are responsible for ensuring that MOLST or POLST move across all these care settings. And in New York, we use that word MOLST, but that's because they're medical orders. It's like a prescription for end-of-life preferences. And then versus advanced directives, the patient or the family is responsible for ensuring access to that healthcare proxy at the time that it's needed. And so I can tell you, I keep my healthcare proxy in my wallet, and it's stored right between my license and my insurance card. And it's a little mini legal document. You are welcome to order our advanced care planning booklets. They're provided for free. We print hundreds of thousands a year for use in the communities across upstate New York. And on the back of those booklets, there's tiny little legal healthcare proxies. And that's exactly what's in my wallet. Because if I show up at UHS, they're gonna wanna know, like, who is she? And how's she gonna pay? And then they're gonna find my healthcare proxy in between those other very relevant documents. And then from a review and renew perspective, medical orders, you know your prescriptions, they're not supposed to be used forever, right? They're either reevaluated or rewritten or renewed. There's a lot of different ways you could think about it. Even when it's for a chronic disease that you're gonna have for the rest of your life, right? The physician or the nurse practitioner or PA maybe looks at that script and says, does this still make sense? Does the dose still make sense? And same thing with MOLST. The physician and PRPA looks at the document, looks at the patient, and says, has there been a change in health status, prognosis, goals, right? Have they changed their mind? And they're thinking through that when they're reviewing and renewing these documents. Providers are responsible for reviewing and renewing MOLST orders at least every 90 days in our state. That's been true since 1987. We had the first DNR law in the country. And that 90-day review and renew requirement has held since 1987. In hospitals and nursing homes, they review it more often, typically every week in a hospital, because those patients might be changing really rapidly, and typically every 60 days in a nursing home setting. We had a question here from Kim. For patients with developmental disabilities, how does the parent transfer medical decision-making ability, or does it automatically transfer to the state? This is a big issue we've encountered. We're definitely going to talk about who's the right decision maker for patients with developmental disabilities who lack the ability to complete a healthcare proxy, to address that example of, the child is going to outlive the parents, and the parents are realizing, oh wow, who's the decision maker going to be in the future? And you guys can get into discussions about guardianship and other items, but there's also a surrogacy process in our state embedded in this work. And for patients with intellectual and developmental disabilities, there's a separate surrogate list for that patient population that requires active involvement. And we're going to go through how that list proceeds, because it does consider the role of other family members above, for example, the state, where that's possible. And please let me know if I didn't answer your question, Kristen. Review and renew of the healthcare proxy. Please at least look at that document once a year for yourself and make sure it's still current. When I do these presentations for patients and families in the community, inevitably somebody realizes that their healthcare agent is dead, or that it's their ex-husband, or that it's just not who they want anymore. And so please look at those documents for yourself. Only you can update those documents. Those documents never expire in New York unless you indicate an expiration on them. Today, if you complete a healthcare proxy and you're married and you designate your spouse, and then next year you get divorced, that is the only exception to the expiration rule, where that healthcare proxy will automatically expire on a divorce. That was actually relatively new change in the law. What happens if the provider refuses to review it at 90 days? We had this happen. He said, it's not needed, it remains valid. That is true. It does remain valid, but you're correct that things should be reviewed and renewed. And the reason for that is because other physicians who encounter these documents and other NPs and PAs, including EMS, emergency medical services, who's asked to act on these documents called MOLST, right, in an emergency directly, because they're not advanced directives, they're a prescription for how to treat somebody. They get suspicious if you see a MOLST that was last completed 2 years ago, even though sometimes patients remain stable, seriously ill, but stable. And their situation hasn't changed, and their goals haven't changed, and their preferences haven't changed. Because MOLST is always supposed to be about current health status, prognosis, and goals, they're suspicious. They're like, is this still their current health status, prognosis, and goals? Because it hasn't been reviewed in a while. So while it's legal and valid and must be honored legally, it is not correct to say nothing's changed, so I don't need to re-sign this medical order. The equivalent would be, nothing's changed with you, diabetic patient, so I don't need to re-up your insulin. I don't need to re-prescribe your insulin. That doesn't make sense, right? And I realize that the 90-day review and renew requirement from the provider perspective can seem burdensome because they're like, nothing has changed. This person still has dementia. They're managing in the community. 90 days can seem frequent, but these are very sick people. So things can also change quickly at the end. And absolutely, they should be reviewing and renewing on page 3 of the New York MOLST document. Review and renew in their chart is not sufficient because that's not going to cross care settings. And in fact, we'd ask them to use MOLST so then it's transparent everywhere when it's been reviewed and renewed and updated. And we would say that documenting their refusal is, not, the physician is not behaving correctly in that circumstance, and you have to know it's a physician because those are the only people who can complete a MOLST for a patient with intellectual and developmental disabilities who lack capacity and can't do a healthcare proxy. And if you want to reach out to me afterwards, this question came in anonymously, I am happy to speak with that physician's office. And I'll put, my email will be at the end of this. Because that's a really important piece of clarification. Sure, it remains legal and valid, but they're missing the point of maintaining a medical order for somebody. So what is the value of a healthcare proxy for people with developmental disabilities or intellectual disabilities? Just like the general population, they deserve to choose who speaks for them when they can't make their own medical decisions. And when they're age 18, they, evaluating their ability to do a healthcare proxy makes sense because that's one of their rights. If they have the ability to do a healthcare proxy, they should get to do it, just like all of us. If they don't have that ability, then there's a separate pathway, and we'll talk about surrogacy for those folks. So community conversations on compassionate care is the 5 easy steps. We have 5 easy steps to completing advanced directives like the healthcare proxy or the living will. So you've learned about advanced directives today. Hopefully you've removed some barriers. I can tell you doing a healthcare proxy does not make you need one. I have had one for over 10 years and I have never needed it. And completing that healthcare proxy and living will for yourself and bringing that conversation to your family. If you don't want to do the living will, like I said, it has very limited value. Don't feel like you need to do it or that you're missing out on something. From like a required documents perspective, the healthcare proxy is vastly more important in New York than the living will. And then review and update it. Look at it at least annually. Dr. Brahma has a great saying, no pumpkin pie till you tell me how you want to die. And obviously we're coming up on Thanksgiving in the next couple months. So consider distributing healthcare proxies virtually around your Thanksgiving table. I certainly did this actually at Easter in my house. My family's Catholic, and I made some great resurrection jokes. And actually we had like a nice healthcare proxy party and a conversation about what mattered most to us, what was important to us. And some of the people at the table actually had completed healthcare proxies that other family members had no idea existed. And so it was really good to have that conversation as well. There's some really big differences between consumer attitudes versus their actions on healthcare proxies across upstate New York. We have completed this survey of 39 counties in upstate and western New York a couple times now, and actually the results haven't really changed in over a decade, but you guys in the southern tier, you're doing all right with healthcare proxy completion compared to the other regions of upstate New York. Certainly you've got an edge on central New York and Utica. And you have the vast majority of your patients and families believe these documents are important. That's that orange bar. However, only 44% of them have completed this. And this is among people age 18 and older. If we did this survey among people 65 and older, the rate of completion would be significantly higher. But these documents are appropriate for everybody 18 and older. Anybody could have an accident, a sudden illness or injury, and they might recover from that and be fine. And their healthcare proxy might have only been needed for a short period. But there's also always the possibility of that event being very serious and facing potentially death or dying. Definitely is the case with COVID, right? We're seeing, people in their 20s dying of COVID and suddenly, where decisions need to be made really rapidly. And without a healthcare proxy, decision-making can be delayed, and it certainly can be very confusing for family members, and it can spark a lot of conflict. We got a question here. In the hospital at discharge, we're supposed to print the MOLST. So at the PCP level, are they printing also every 90 days? But what about patients who don't see their PCP every 90 days? Are EMS agencies able to access MOLST? These are all awesome questions. And I feel like Kristen is like introducing the next section, because the next section of my presentation is all about MOLST. And so we have the MOLST system that is used widely in your part of the state. PCPs they don't have to, even if they don't print every 90 days, some PCPs are loading the MOLST to the like my chart kind of experience, the patient portal. And others are so that patients can download that review and renew page for themselves and print it out. Because you have MOLST so well used in your part of the state, it's possible forms have been reviewed and renewed electronically, even if they weren't reprinted. And so obviously you're checking the registry every time you interact with a patient. And that lets you see when those reviews and renews have occurred. We know some patients find it burdensome to carry page 3 and 4 of their paper MOLST form. And again, this is the general population. For patients with intellectual and developmental disabilities, they're required to have that on them because they also have to have the appropriate OPWDD checklist attached to their MOLST. And eMOLST generates that document every time. But for the general population, sometimes they only carry page 1 and page 2 on them because like it's so much to fold up and so much to keep on them at all times. So even if, again, it's not been reviewed and renewed, it's still legal and valid. Many PCP offices do print every 90 days, but not all of them. If you're not seen every 90 days, PCPs have a relationship with their patients where they can look at and say, patient hasn't been admitted, right? Patient hasn't had a serious change in health status. None of their specialists have contacted me and said that they've had a significant change. I haven't heard from this patient who's had and you know, I know that they're relatively stable. And they may review and renew it, you know, and this has been true since the 80s, to indicate no change and to re-up that order, just like they might not make you go to the office to get a renewed script. And don't worry about, you're not rushing me at all. And we've also seen in the pandemic, because so much more telemedicine is used, sometimes there's also been some relief on HIPAA rules with electronic communication with patients. And so some physicians are actually openly emailing. If they don't have access to a secure portal like MyChart, they're just openly emailing the MOLST to patients because that's the best way to get it to them. And then printing on pink paper and snail mailing so the patient also has a physical copy. This is an important time to mention copies, faxes, and electronic representations of that New York MOLST are all legal and valid. That's that pink form that we're going to talk about. Who keeps the healthcare proxy once it's completed? What if the patient or family member loses it? How do you get a copy to prove someone is the healthcare proxy if it's lost? So I'll tell you what I did. There's no rule in New York about how you have to do this. We recommend that you give a copy to your physician or your primary care office. If you receive specialty care from other offices routinely, give them a copy. If you know you'd end up at a certain hospital, like here, I'm here in Rochester, there's like a very good chance, there's a strong chance I'd end up at Strong, just based on where I live. And so I know that the University of Rochester has a copy. I've loaded a copy personally to the Regional Health Information Organization, the Rochester RIO in my area. And for you guys, I think it's Healthy Connections because Southern Tier and Syracuse merged. And I emailed a copy to my family members. You know, I just took a picture of it, sent it out via email so they all have it electronically. Copies, faxes, electronic versions of that healthcare proxy are all legal and valid. This is certainly not a document you want to put like in a lockbox that like can barely be accessed. It should be freely available, you know, copy in your wallet, right? My husband has a copy of my healthcare proxy on his phone. And so that's how you would, you definitely need to substantiate that this healthcare proxy exists, because providers are not allowed to trust you when you show up at the hospital and say, I promise I'm the healthcare proxy. You know, that's not a thing that we can do in our state. Thanks for that question, Brittany. It's hard to find witnesses to complete healthcare proxies for individuals with intellectual or developmental disabilities. Is there a resource? And I'm going to leave that one for Laura Bavacqua to answer. Because those witness requirements are very specific for those patients, again, because they're considered particularly vulnerable. And yes, it's a significant struggle. I can tell you one of the witnesses has to be a physician or psychologist with experience in intellectual or developmental disabilities. And it's very specifically outlined in the law what that means. And this would be a great opportunity to create a listing of who in your region, and you guys could do this locally, who could meet those witnessing requirements. I know that you have some extremely generous physicians and psychologists in your community who will work to get these done for your patients, but you have to know who they are reasonably to be able to get in touch with them. So some definitions: POLST, national model; MOLST, here in New York. More than a decade of research has proven that these programs much more accurately convey patient preferences, way more likely to be followed by healthcare professionals because they're so specific. And basic history of MOLST and EMOLST. EMOLST has been used for many years in your part of the state. We're very fortunate to have UHS, honestly, having led the charge there. And many of your nursing homes use EMOLST. Lourdes uses EMOLST. It's like 80% of the nursing homes, I think, in Broome County alone use EMOLST, and several in your outlying counties use EMOLST. So you have great EMOLST penetration in this part of the state, and we are enrolling folks from your part of the state, and it's growing all the time. Mark these down for myself. And what's great about EMOLST is it allows these orders to be visible across all these care settings. So for people with intellectual and developmental disabilities, since 2011, OPWDD has approved the use of MOLST for those served in the OPWDD system. The MOLST legal requirements checklist written by OPWDD has to be attached. And this is only for patients with intellectual or developmental disabilities who can't complete a healthcare proxy. If they can complete a healthcare proxy, and they've done one, and the patient can't make decisions, but maybe the agent can, make these, very end-of-life medical choices for somebody when they're clinically appropriate for it, then that OPWDD process is not needed. There still might be notifications that are needed, depending on the setting the person's coming from. MOLST is an end-of-life care transitions program that's honored in all these settings, including by EMS. There was a question asked earlier: does EMS have access to EMOLST? In your part of the state, EMS does not have access to EMOLST. Well, there are a handful of people from EMS who are enrolled, but EMS really wants you to keep printing these documents on pink paper. They said there's no substitute when you're working in the back of an ambulance on a bumpy road to just having it right in front of you on that MOLST form that indicates the patient's preferences. But MOLST is legal in all of these settings, which is what makes it so unique. It's not just advice about someone's preferences the way an advanced directive is. It is very specific about the interventions you can or cannot perform on that person based on their health status, prognosis, and goals. And it is also the only tool for both resuscitation orders and intubation orders. Being connected to a ventilator, having a tube down your throat, having a machine breathe for you in our state. It's the only source. There's no other document in our state for resuscitation and intubation orders. Those old non-hospital DNRs, they're on white paper. You may have seen them. They're absolutely insufficient for these very seriously ill people. So EMS has a set of protocols they're required to follow. And some of you may have experienced this if you've witnessed EMS come to your home or to a family member's home. You don't get to say, oh, do this, not this. EMS has to follow a certain process. MOLST allows them to break from that process and follow MOLST. So that's how it's the only tool for resuscitation and intubation. And the goal of MOLST is to improve the quality of care these very seriously ill people receive at the end of life. It translates those patient wishes, which are kind of general, and their goals into specific medical orders that apply today. And that should be looked at to consider, is this still relevant? Is this still their health status, prognosis, and goals? Do these still match up? These orders that we wrote, does it still match up to the goals? And that's the job of the provider, the physician, the NP, or the PA. And again, for patients with intellectual and developmental disabilities who don't have that healthcare proxy, they can't do one, it's only those physicians who can do the MOLST for those patients. MOLST is a complement to traditional advanced directives. It's not a replacement. So if your grandma has a MOLST but no healthcare proxy, that is not sufficient. Grandma still needs to have a healthcare proxy in case she loses capacity, because over 70% of patients will lose capacity before they reach the end of life. So who needs a MOLST? Who should be offered one of these things? No one has to do a MOLST, but who should be offered this? And research says, like, when you offer this conversation, somewhere between 80 and 95% of patients will want to have this discussion because they recognize clinically that they're appropriate for this. There's some percentage of patients who say, I don't want to have this conversation and I don't want that form, and that's fine. This MOLST is voluntary. It's never required. But for patients who are seriously ill, so this would be patients who have specific wishes about what they want or don't want. Patients who live in a nursing home or require long-term care services at home or in another setting like assisted living or potentially a group home. And patients, it wouldn't surprise us if they died in the next year. We also have some more additional clinical criteria written for our physicians, our NPs, our PAs, our RNs, and our social workers to be looking at when they're thinking about, is this person maybe appropriate for MOLST? Should I bring them to the doc or to the provider for additional consideration on this? And sometimes care managers play that role in primary care offices and in other settings to say, did this person become appropriate for MOLST? Do I need to raise this with the provider? And so RN care managers in particular, of course, because they can assess health status. And I will tell you for these questions right off the bat, the only thing I did to change these questions for this presentation is add with DD to every question. Because for the general population, the questions are the same. That's because these are clinical considerations. It's not based on their developmental disability that they might be appropriate for MOLST. It is because of how seriously ill they are. So does the person have a preference, or their healthcare agent or surrogate have a preference to avoid or receive specific life-sustaining treatments? This would be like my grandfather. He didn't have developmental disabilities, but he was like 85 when he first did his MOLST. He's 92 now, he's still doing well. But he had preferences at age 85, like many 85-year-olds would. And he said, I lived a good life. You know, if I die, don't try to bring me back with CPR. You know, that's just the Lord saying it was my time. Let me go. You know, so he did his MOLST originally at age 85 that said that. And, you know, we can talk about it, but page 2 of his MOLST, where he had, you know, the option to list other life-sustaining treatments, indicated aggressive treatment on page 2 while he was still alive for many years. Does the person with developmental disabilities live in a nursing home or receive long-term care services at home or in a group home? So those patients are sort of straightforward. Would it be surprised if the person died in the next year? Do they have advanced frailty? And so certainly my grandmother, when she did her MOLST, again, she didn't have developmental disabilities, but she had heart disease. It was pretty advanced. She was age 83, 84. And, you know, her physician said, it's time to start thinking about this stuff. Like, it wouldn't surprise me if you live longer than a year, but it also wouldn't surprise me if you died the next year. And she also had preferences. She was age 83, 84, and she knew she had heart disease that was pretty advanced enough to be considering some serious procedures that could be done maybe to extend her life, but potentially at the expense of quality. And does the person with developmental disabilities have one or more advanced chronic conditions? So Dr. Dwanzik gave the example of that patient with rapidly progressive dementia. Do they have end-stage COPD? And that's chronic obstructive pulmonary disease. It's a lung disease. Or CHF, congestive heart failure. That's what my grandmother had. Or a serious new illness with a poor prognosis, like metastatic cancer. And then does the person with developmental disabilities have decreased function, increasing frailty, progressive weight loss, 2 or more unplanned admissions in the last year, have inadequate social support, need more help? You know, and Dr. Dwanzik gave you all those great examples of when you should be thinking, this person is declining pretty quickly here. There are certain conditions for patients with intellectual or developmental disabilities that may make them more likely to get dementia or something like that. Or the trajectory of certain illnesses may progress differently because it's co-occurring with their developmental disability. But it's important to remember that it's not the developmental disability that is causing us to say, is the person appropriate for MOLST? It is because of those other clinical factors that are part of this person's picture. So MOLST is a standardized process. The result of it is a set of medical orders that everybody can honor. And when I say everybody, I mean all healthcare professionals. They're obligated to honor MOLST in our state when it's been completed. Patients have the right to make their own decisions, including talking about values, beliefs, and goals with their healthcare providers. So MOLST is not supposed to be, if your heart stops, you want us to start it? All right, if you stop breathing, do you want to be on a breathing machine? Okay, check, check, sign. Like, that's not how it works. Patient gets to understand their health status and their prognosis first. Then patient gets to share values, beliefs, and goals, what matters to them, and their provider needs to listen, because then the provider's job is to respond and provide advice about the different treatments that are available to the person. Talk about the disease trajectory. What's the likelihood resuscitation might be beneficial to help the person accomplish their goal? You hear my grandfather's goal was, you know, I've lived a good life. If I died in my sleep, you know, or if the Lord said it was my time, that would be okay, right? Physician's gonna recommend something different than if grandpa had said, it is most important to me. I've always wanted to live to be age 90. That is like a huge goal for me. I would do anything, including accept like lots of intensive interventions to get to that next grandkid's wedding. I would do anything to continue to, you know, go out and play cards with my friends on Tuesday night. You know, the provider's gonna recommend something different versus when he says, you know, I've lived a good life. If I died, it would be okay. But I still really appreciate going to play cards with my friends, traveling to Florida in the winter, you know, going to Cuca in the summer, all of that kind of stuff. And so I'd accept interventions on a trial basis that might help me continue to get to do those fun things that I love. And then, so the physician or the other provider, if you're part of the general population, makes shared informed decisions with the patient, right? And this is a shared discussion. So the patient gets to respond and say, I heard what you said about resuscitation, but I still want to try it. You know, I'm 35 with advanced cancer and I would do anything for one more day with my kids maybe. And so, you know, that's shared decision-making. Physician making recommendations or other provider, and then responding to those patients' concerns, preferences, thoughts. But, you know, a lot of times, you know, we don't ask patients to go into the room and, you know, providers don't say, do you want this antibiotic or this antibiotic? Either one's fine with me. Resuscitate or don't, it's fine. Either one, right? You know, that's not the way those decisions should happen. Patients also have the right to always receive comfort while having their treatment preferences honored. So while resuscitation, intubation, those are not comfort measures, there may be other measures that could be taken along with those interventions that could enhance comfort sometimes. And certainly with other treatment preferences, you know, that's definitely possible. And as you transition to really comfort-focused treatment, you know, that is the purpose of something like a hospice, potentially. So patients with developmental disabilities, their rights are the same as the general population in terms of working through this process. They can't always speak for themselves, so someone else has to represent them in this conversation. So from the provider perspective, these are the things they should be thinking about. And I say provider because this is a prescription at the end of the day. MOLST is a prescription. They need to allow sufficient time. They need to listen to the patient's goals. They need to be present and not speak in a way that would end up with unintended consequences. And we have a process for these conversations. So that's the 8-step MOLST protocol. It's only step 7 where the MOLST is completed and signed. And there are some additional considerations for patients with developmental disabilities who lack capacity or who have capacity to make these medical decisions. If they have capacity, they follow the same pathways as the general population. Or potentially they have capacity to do a healthcare proxy, then they follow, that pathway can be used. And then when they don't have a healthcare proxy or they can't do one, that's when there's a 1750B process. And you can see the relevant checklists for patients with developmental disabilities are sort of highlighted in pink here. These are the legal requirements that have to be followed. Identifying the correct 1750B surrogate. This is the surrogate list. This is the answer to that question that was asked earlier. What happens when patients can't do a healthcare proxy? Who decides? And importantly, who decides when after the parents have died? So first, First things first, if the patient has a guardian, they're number one on the list, 17A guardian. You gotta read those guardianship papers carefully. Sometimes these guardians are prevented from making end-of-life decisions. And in those situations, you move down the list. You don't wait to redo guardianship. These people are seriously ill, and like Dr. Twanzik said, you don't want to delay decision-making inappropriately for them. So if they don't have a guardian who can make end-of-life decisions, then you move down the list to spouse. If they're not married, you move down to their parents. If their parents have died, then you move down to any children that they might have. If they don't have any children, you move down to their siblings, and then other actively involved family members after siblings. All of these people have to be actively involved. And this is a different standard than the general population. The Willowbrook CAB, I doubt that you see these patients in your part of the state, but that's the Willowbrook Consumer Advisory Board. These patients came from a specific facility in New York and have a specific representative body for them. In your part of the state, you're unlikely to see them. And so after actively involved family member, effectively, most of your patients, if they don't have any family to make choices for them, then there's the surrogate decision-making committee, who you will hear from later. What avenues do we have to advocate for individuals with DD whose families want full code, but we believe they're making these decisions based on their wishes, not the patient's? I have encouraged a palliative consult so family can speak with the provider about the individual's prognosis, possible interventions, and chance of success. The family has declined and continues to want full code. I wouldn't mind if this is what the individual wanted, but I don't think this is the case. So that's a very interesting circumstance where it sounds like the individual might have some capacity to engage in this conversation to some extent. Because if you think that the individual doesn't want this for a certain reason, the physician is obligated to incorporate the patient's preferences to the extent they're able to engage in this discussion. And that is the purpose of capacity determination and evaluation that goes into these conversations. But this is a very difficult circumstance, especially with this patient population. When they have a short prognosis, we would encourage their PCP, and perhaps this is coming from a PCP, I don't know, it's anonymous, to raise this discussion directly with the family. If they're already appropriate for MOLST, which it sounds like potentially they are. Does the surrogate list work for the MOLST and the healthcare proxy? No, the surrogate list is only for these end-of-life decisions. It is not for doing a healthcare proxy. So it's not like the 17A guardian could complete a healthcare proxy on behalf of the patient. Absolutely not. Only the patient could do a healthcare proxy. If they lack capacity to do a healthcare proxy, they will not have one. And the surrogate list is used instead for these very complex people with end-of-life decisions. What does actively involved mean? Thanks, Erica. So this means that it's not somebody who just like checks in once a year or has their name on a bunch of paperwork. It's someone who has a relationship with the patient. And this is a different standard. Like I said, honestly, it's probably a better standard for DD patients than it is for the general population. I wish actively involved was written in for the general population, but it's not in our surrogate list. And remember, this is just for OPWDD patients who can't do healthcare proxies that you turn to this list. And it means they've got a relationship, they know the person, they're frequently involved in their lives. It doesn't mean they have to live in Binghamton, but they have to try to, they're trying to talk to the person on the phone, or FaceTime during the pandemic, or take this person on outings, visit them. It is not like some rigid standard that says, yes, you meet the criteria for active involvement, or no, you don't. It is a judgment. And the attending who's responsible for this process, it gets to participate in that judgment, and certainly staff get to participate in that judgment and provide information to the medical team to say, yes, this sibling has been really engaged in this person, in this person's care in their life. Does the surrogate list work for making other medical decisions in absence of a healthcare proxy or a guardian? Yes, that's the purpose of the surrogate list, is to make medical decisions for these people, like if there is no guardian, right? Or if the guardianship excludes end-of-life decision-making, you use these other surrogates on this list. And again, it's only for patients who can't complete a healthcare proxy. We would have offered a healthcare proxy already for these people. Unfortunately, sometimes what we see is patients with intellectual or developmental disabilities don't get offered a healthcare proxy until they're so seriously ill that they can't do one, even though they could have done one years ago and before their dementia progressed, and that they should have been offered one at that time, to be honest. Okay, so briefly, I'm going to show you our MOLST tool. And so I'm logged in, or I'm logging in on our test site. There's no PHI here. And I'm going to search for our patient. Dragonfly. And we found an exact match in Binghamton. So we're going to pick him up. And his physician or the other team members, they can work in a team, but only the attending physician is responsible at the end of the day, is part of this discussion. And this is what they're working through. So they're not converting from paper. This isn't a child. They didn't come from a mental health or correctional facility. They do have developmental disabilities without capacity. And you can think about some of the complexities that they're working through here. And what they're completing is the OPWDD MOLST checklist, the 1750B surrogate checklist, when you're working with this patient population who, when they can't do a healthcare proxy. Again, if they could do a healthcare proxy, MOLST will capture that pathway as well. And we're going to say they're severely frail, but not at high risk of dying in the next 6 months. You can see these questions about kids are disabled. And so the prognosis for this patient wouldn't surprise us if they died in the next year, but they're not eligible for hospice. If the patient has a healthcare proxy, right, then the healthcare agent pathway is the pathway that we're going to use for them. By answering this question up here, we've already said that the patient lacks medical decision-making capacity. If there's no healthcare proxy and they lack the ability to do one, then we're using the 1750B surrogate list, and you see the surrogate list is embedded for the physician and the medical team right here for them to use. So they don't work in the wrong order. And this is the goals for care discussion, what matters to the person, what's important to them. Maybe it's focused on functionality, time with family. And they can write as much as they want in this box. And I know that the folks at UHS and the folks at Lourdes in particular, you know, they're very detailed when they do a lot of these goals for care discussions on those palliative teams who are often the ones leading these conversations. Again, PCPs and others can also do the MOLST. I'm keeping it simple for the purposes of the demo. Maybe this was originally done in the hospital, right? Maybe it was done in the nursing home. Maybe it was done in the community. In the community, we have to answer this hospice question, but I can tell you it's not going to change the legal pathway for patients with developmental disabilities. So we're going to say it's done upstream in the doctor's office, which is ideal. You have a relationship with that physician, and the patient knows that physician, and the healthcare proxy knows that physician if the patient has a proxy. And if they don't, that family member knows that physician. And so the relationship is just different. The conversation is different. It's calmer. It's held appropriately early, but not too early, right? This isn't for people with, you know, who have 10 years to live. This is for patients. It wouldn't surprise us if something happened to them in the next year or two. This person works with an individual, has a legal guardian, and they also have a MOLST that the guardian was okay with. There have been times that the guardian asked the staff at our group home to go against the MOLST. Yeah, no, you have to follow the MOLST. Similarly, you also want to really clarify how that MOLST was completed, because if the 17A guardian was not the decision maker, who was? And you really need to clarify that piece there, because the 17A guardian should be the decision maker when someone can't do a healthcare proxy. So I'm very curious about this piece there. But you're correct that in a medical emergency, the MOLST is what is honored. You don't just say oh, we've got a family member screaming at us. You know, let's just throw all this work out the window. That being said, if you're threatened with physical violence in New York, you're protected. Like if family member is insistent on you resuscitating somebody, you're protected to ignore the MOLST that says DNR in that situation. And that's actually happened, you know, and, you know, EMS transports, And then in the hospital, potentially, some hospitals have needed to call the police on family that has gotten so aggressive. And they're able to stop resuscitation. Importantly, if the MOLST was completed appropriately by the healthcare agent, and now the healthcare agent has died, right, and you're working with a guardian for additional decisions, the guardian or the other surrogate doesn't get to just overrule what the agent did regarding resuscitation. The agent was selected by the patient themselves, and so they have more rights than in that regard. Just like if a patient did a MOLST for themselves, a healthcare proxy can't say, I'm in charge now, resuscitate mom. I know she used to want DNR, but now that I'm in charge, you have to do CPR on her. PAs and NPs are not able to do the MOLST for OPWDD patients in New York. All right, so eMOLST is going to prevent medical errors. If we tried to select CPR, it wouldn't let us choose something that's medically incompatible. Limited interventions is in line with what this person would like, or maybe even no limits yet. They would accept trials to lots of these things. They'd still go to the hospital, and maybe the physician said, it's not time yet to talk about these items. We're going to skip those. The goal of intubation would be to return functionality and living in the group home. And the name of the decision maker here is that 1750B surrogate who is documented. All right, so now this is the legal stuff that we haven't captured anywhere else. We said this was an actively involved sibling. And then we have to document, and when I say we, I mean the attending physician, and the medical team can work on documentation, of course, with the attending physician. I think Amy plays a big role in ensuring all the documentation gets done correctly for with the palliative team patients. But you're capturing what is the life-sustaining treatment that's you're asking to withhold or withdraw. In this situation, it was resuscitation actually only, right? We didn't even withhold intubation. We said a trial. You know, if he gets pneumonia, we would try intubation to recover from that and return to this previous functional status. And the physician may agree that's totally appropriate, and that might work given the person's stage of their illness. So the question from earlier about that guardian who wanted to change the MOLST, the guardian struggles. The question asker said the guardian struggles when in emergencies and when things like go south. And that's why ensuring these conversations are really goals-based is so important, because, and I would encourage reflecting back on those goals instead of getting like legalistic with family members, because that's not helpful for them to cope with their loved one dying. And this happens for patients with developmental disabilities, and it definitely happens for patients in the general population. Like it's not specific or exclusive to them. Certainly the guardian could update the MOLST if they felt like it no longer reflected the person's wishes, but it's a physician's job to keep this conversation patient-centered. I think Lauren's gonna give me the yank here. And this has to come from two physicians. So for example, Dr. Dwanzik and another physician or psychologist who's confirming that this patient lacks capacity. And so these people are some of the same people that could be witnesses, those special requirements on the healthcare proxy. And then the physician has to talk about the person's terminal condition, right? And it might be congestive heart failure, but they're not in the final stages of it yet. And they would be more descriptive than I am being here. Or if the patient's permanently unconscious, or medical conditions other than developmental disabilities which require life-sustaining treatment, they're irreversible and they'd continue indefinitely. And so, physicians actually might consider CHF to fall into that category. And this is all physician judgment, right? Life-sustaining treatment, why would this be so burdensome? And this isn't about the person's developmental disabilities, right? It's about their medical conditions other than developmental disabilities. We didn't withhold artificial hydration or nutrition, so we don't have to do that section. And this document had to be done by 2 physicians who agree clinically that this is the right route for this patient. And then we have notifications. So this is where we get into a notification of patients in residential facilities. You have to notify the facility director as well as MHLS. If they're not in a facility, right, they're living in the community, maybe with their family, you notify the director of the local DDSO. And there is, you also have to tell the person with the developmental disability about this process. So this was done in the PCP office. And then the attending physician has to say, I've done this process correctly. I engaged my team. Everybody has been notified in accordance with the law. And I'm putting my name to this, and only licensed physicians can do this part of the process for these patients. Specifically, there are waiting requirements. When you have notified 48-hour waiting requirements for some of these notifications, right? So at least 48 hours prior to implementation of decisions to withdraw, or the earliest possible time prior to decisions to withhold. Here we're only withholding resuscitation. We're not withholding these other life-sustaining treatments. So EMOLST is going to tell us we missed a section. And we can see which section it is. There's going to be a pink line that comes up on the right side. Oh, and who made this decision, right? Who witnessed it? And the second witness was our nurse. And that was the decision from the 1750B surrogate, not somebody else. The attending physician is the only one who can see this section, and they answer questions, choose secret image, and sign the orders, and they're doing it from their office. So now at the end of the process, we have both the MOLST and the OPWDD checklist that always must be attached for these patients. I can't stress that enough. We can't honor MOLSTs for these patients that don't have that OPWDD checklist because it doesn't prove that the process was done correctly or well at all. And so you see everything is checked off. This is what decision deferred looks like on these documents. And then we've got the OPWDD checklist attached, right? That indicates who was the decision maker, how did these decisions occur, why are these decisions appropriate for this person? And this has to stay attached to the MOLST at all times. So this should be printed and it should travel with the patient. I know it's a big packet, but it's really critical for these vulnerable people.